Yeah, for the gingival to be, we give external bevel, here we give internal. So the next one would be undisplaced flap. Again the same incisions. What are the three incisions can I have? Gingival bevel, clavicular, circular, or gingival incision. Same thing, but what you do is before the procedure, you use the probe and pass through a transgengival. What is a transgengival probe? You run it through the connective tissue and the junction epithelium and touch the bone. So when you touch the bone and see the depth, the first incision that you are giving, that is an internal bevel incision, should be on the base of the mucogingival junction. Are we clear? So then the second incision and the third incisions are the same way. Okay? So the flap is elevated 1 mm apical to the mucogingival junction. Yeah. So the final procedure would be the apically displaced flap. Apically displaced flap, the same story for everything, except that finally you will apically place the flap in the bone and I'll tell you what it is. So basically, the first time I said modified women flap 1 to 2 mm apically. For here, we cut 0.5 to 1 mm apically, the incidental bevel incision, and you will do the procedure only if the attached gingiva is greater than 3 mm. Otherwise, you will not do this procedure. And the flap is placed in the tooth bone junction. You will bring it down apically. Yeah? And then this, see, first thing I said, eliminate the pocket lining, modified movement. Second one, reduction of the pocket depth, undisplaced. And the third one, apically displaced, would be your pocket eradication. So basically, this procedure, apart from pocket eradication, also done for the widening of the width of attached gingiva. So when they ask a flap to increase your width of attached gingiva would be, and mucogingival procedure would be your FGG, free gingival graft will increase your attachment. And basically for this, for the adequate mobility, you can give the vertical incision. So distal molar flap for the maxillary incisors, basically when there is a distal pocket you give, but for the maxillary the complication is the tuberosity will be very bulbous, but the advantage is it has a beautiful attached gingiva. Disadvantage is it's abruptly descending. Yeah, it's abruptly descending. So you need to consider the pocket depth, tuberosity, distance, everything. So if you need to do a resective or you need to have an adequate keratinized tissue, the procedure that you will do would be your modified distal wedge procedure. Remember, for the maxillary molar, you will give a parallel incision which will join the clavicular incision and give a transverse incision. And when you suture it, it should not overlap. You need to cut off the extra and then suture it. Whereas for the mandibular molars, since you have a retromolar pad, the disadvantage is it doesn't have that much of width of attached gingiva. You should not give lingually or in the alveolar mucosa the incision because it will bleed abruptly. And so, if in case you are going to do a regenerative procedure or if the keratinized tissue is limited, what you do is this kind of incision, not a parallel incision, converging incision. Yeah? So this procedure is distal wedge procedure. The previous maxillary molar what procedure? Modified distal wedge. For the mandibular molars, it's a distal wedge procedure. Incision should follow wherever the attached gingiva is more. If it's more here, it should be this way. If it's more here, it should be this way. If it's more here, it should be straight. Are we clear? So yeah, so finally you're healing after flap surgery. So nothing much, up to 24 hours, only the blood clot will be formed. 1 to 2, 3 days time, you will have the blood clot replaced by the transudate or the exudate with the bacteria, where the epithelia will migrate to the flap border. And in 1 week's time, the clot will be replaced by the connective tissue and it will gain the epithelial attachment through hemidesmosins and lamina, basal lamina. And in 2 weeks' time, you will have your collagen fibers getting aligned parallel to the teeth, but it is a immature collagen. And in 1 month's time only, you will get a fully epithelialized gingival crevice with a well-defined epithelial attachment. So finally, your functional arrangement of the supracristallin fibers will be given. This will be the final thing. Yeah? So we are done with the run-through of the topic. So are you clear? As I told you at the beginning of the topic, do you remember at least 5 keywords? Yeah? For whatever it is, that's more than enough. So, acknowledgement. I would like to thank my principal, Dr. Sivapada Sundaram, who has always given me a motivation and support. And I am very, very proud to tell you here one thing is He is the adaptation author of Shapers, the Bible of oral pathology, and I am sincerely grateful for him to give me an opportunity to contribute a chapter in Shapers. Yeah, so I would like to thank the Professor and HOD, Department of Periodontics, thank you much for giving the opportunity to add something to you before your final exam. And I would also like to thank my kids, my source, my lifeline, my husband, and also my parents. It's a great support system for me to, travel, enjoy, go through anything, whatever I want to. They're there to take care of that of the stage. And finally, I would like to thank the universe for giving me an opportunity to present this. Despite of this very insightful everything, thank you very much. So, sometimes sacrifice is 100% necessary. What it means is whether it's a surgery or it's a life, till you can manage conservative, non-surgical therapy, antibiotics, everything will help. Once it crosses a stage, always stay brave enough, whether it's a relationship or it's a tissue, cut it off, chop it off. To have a healthy instead of a healthy mind. Thank you.
Thank you, Dr. Balaiva. That was a wonderful lecture. I know the topic is very, very vast and you have to run through it. But that's a difficulty I gave all the speakers, I think. And that's named that rapid review. I hope the students will understand and take home the key points. And definitely, ma'am gave an important topics overview. And definitely it was very, very interesting. Thank you. I call upon Dr. Narasimhan, Professor of Department of Prostatics. lecture. I think Dr. Kadir is the next speaker, professor from Wales Dental College, Department of Periodontics, with extensive knowledge. He will definitely make the topic more interesting and the crowd more interactive. Welcome to the dais. Special mention here is Dr. Kadir, myself, we all did the undergraduate during the same time. So he was my junior there.
So good morning everyone. So now I want every one of you to clap yourself for sitting for a long time and listening. Yes. I think there are some students who have gone out and it is very, very difficult to sit for 2 hours in a continuous in one place. Yes. Must late. So the past 2 days, yesterday and today, you people are having a rapid review of Perio. Normally Perio is comparatively a very easy subject, right? Basically we divide into Perio into small headings normally, right? The basic issues, classification and epidemiology, etiology, gingival pathology, periodontal pathology, diagnosis, treatment, implants. That's it. If you read under these headings, it will be very easy for you to understand the subject as well as write the exams. Okay? So, what are the basic issues of periodontium? Yes? So, two soft tissues, what are they? Gingival and periodontal ligament. Hard tissues are? Alveolar bone and cement. So, what we are going to see, just go for the revision is, what is this? So, you have an armpit, you have a nasal bone, alveolar bone, everywhere bone. So, the topic what we are going to discuss is regarding the resective and regenerative osseous surgery. Okay, right? So, I thank Dr. Bhave and Dr. Nandina ma'am have given a brief history before this topic. So the surgical topics and the non-surgical topics, okay, so that you will be having an idea what is the surgeries, what is the flappers. Please remember, whatever we do, either resective or regenerative, we have to reflect something called as a flap. After doing the flap reflection only, we are going for these procedures, right? And can you see what is this one? Laddu. It's a small laddu, a big laddu. Big laddu, see the mouth opening. Can the laddu go inside in one piece? No, very difficult. That is what I am facing now. Within a stipulated period of 45 minutes, I have to push the whole laddu inside your mouth. Okay? I'll try my best because the laddu is a sweet one. Always sweet goes very easily. Right? So we'll try to split it and put it inside. Right? Okay, so the probable questions from this another 45 minutes to 1 hour will be this one. The resective osseous surgery, the regenerative osseous surgery, both can be asked as an essay. The following things will be comes under the short notes: bone grafts, membranes, GTR, CDR, fluid biomodification, tissue engineering. And whatever is there in this slide, it's everything is there in the books. Okay, so I want some 8 or 10 slides only to be taken. I'll tell you what slides to be taken in your notes. Okay, right? So we'll start with the first procedure. Okay, the osseous surgery can be basically divided into 2 types. Either it can be additive or it can be a subtractive. Wherever there is deficiency, you add something to increase the height of the bone near the CEJ. It is increasing height, it is called as regeneration. That is regenerative osseous surgery. Anything you try to keep it at the same level at the time of surgery or little more apical, it is called as resective osseous surgery. So osseous surgery can be divided into 2 types. One is regenerative and resective. Additive is regenerative, subtractive is resective. So the resective means what you do is there is a defect, there is a bone loss has been happened. It is a very sharp margin. You just smoothen it and you go little beyond that time. At the time of surgery, the bone level you are going to reduce it. So that is called as resective osseous surgery. So this slide everyone should take it down. So resective osseous surgery, if it is asked as an essay or a short note, these are the points. Because as Dr. Bhavi Madam told, whenever there is a correction for the examination, we will see the key points. If you write under these headings, each and every point has carried 2 marks. If it is a 10-mark question, you will get 2 for all the 5. Only 1 point if you write even 3 pages also, you will get only the 2 marks. Okay? So, for resective osseous surgery, the definition, indications, where and all you do the procedure, where and all you don't do the procedure, what are the armamentariums involved and steps involved. Okay? So this is very important short notes, very frequently asking, either regenerative or resective, definitely you will be having in your question paper. Okay, right? So the definition, it is there in the book, you don't have to write it. It's a procedure to restore the form of pre-existing alveolar bone at the time of surgery or slightly more apical is called as resective osseous surgery. So I think you should know the architecture, right? Right? There is something called as a marginal bone and there is something called as interdental bone. What is the shape of the gingiva? Normally contour of the gingiva is? Which bone will be placed higher? That is coronally? Interdental bone. The marginal bone will be little bit apical. So there are 3 architectures you should know. One is a positive architecture where the marginal or radicular bone is placed higher and this interdental bone will be placed more coronally. Negative means it is the exact vice versa. And then flat means both the marginal bone and the interdental bone will be at the same level. Because this scenario you should know, okay, it's very important. And see, this is the normal contour. You can see the marginal bone which is higher and the interdental bone which is slightly coronal. So this is the positive architecture or ideal architecture. Total reverse of this is the reverse architecture, where you can see the marginal bone is placed higher, the interdental bone is slightly apical. And this is a flat architecture where the marginal and the interdental bone are at the same level, right? Understood? So this is again a small short notes, actually very commonly asked short notes. You will be knowing that different types of patterns of bone loss can occur in periodontal diseases, right? So can you read the bullets? Horizontal bone loss, vertical bone loss, bulbous bone contour, location important. So now you know these are all the common bone loss patterns can occur. So you have to make it alright either by addition or by subtraction. Okay. So here this is how you. This is a very important bypass question. Once you see an X-ray, how will you know it is vertical bone loss or a horizontal bone loss? The very simple answer is you should draw an imaginary line which connects the CEJ of the both the teeth. Okay? You draw an imaginary line. And you draw a line which is on the bony surface of mesial and distal. If these two are parallel, then it is a horizontal bone loss. If this creates an angle, then it is called as a angular bone loss. So vertical bone loss and horizontal bone loss. Okay, right? And then see here in the clinics you can see there the bone is flat. So here it is very difficult to do a regeneration. In case of a vertical defect, you can do a regeneration very easily. See, there is a vertical defect, there will be something like a cross angulated. So you can put a bone graft, you can do and you can cover it up till the bone level, right? So the crater is it's a depression in the interdental areas. You do the bone loss in the interdental areas. Then bulbous bone contour, as Madam told in the gingival enlargement, this is a false bony enlargement where there is a bone will be more bulkier. The gingiva is normal thickness. So in those conditions, when a patient smiles, they will have a huge gingiva, but it is not because of gingiva, it is because of the inside alveolar bone. So this is a bulbous bone contour. Okay. So what you do? Open it up, thin it up, and then make it to look the aesthetic smile. Then reverse architecture, as I told you, the marginal bone is slightly higher than the interdental bone. And then edges, you can see the sharp edges because of irregular bony formation. It's a elevations or it will be present in between the two teeth. These are all called as ledges. And furcation involvement, you know, right? How many grades are there in furcation involvement? 4 grades, very good. So 1, 2, 3, 4, and all the 4 furcation involvement, there will be a bone loss in the interdental area except the incipient lesion. Okay. So the types of bone removal, these two are very important. Why are question? One is osteoplasty, another one is osteectomy. So osteoplasty is just the shaping of the bone. Without removing the supporting structure, we just shape the bone. That is called as osteoplasty. Osteectomy means removal of the bone, right? So shaping is termed as osteoplasty, removal is termed as osteectomy. So indications for resective osseous surgery. You all know if it is the bony margins are inconsistent, you are going to do a resective osseous surgery. The main aim of a surgery, if there is a irregular bony margin, the gingiva won't adapt properly, there may be a chance for a pocket formation. Okay, so definitely the resective osseous surgery, inconsistent bony margins will be a indication. Okay, and then reverse architecture, you know, I told you what is reverse architecture. One wall defects, buttressing bone formation, ledges, craters, furcation defects, and in case of a crown lengthening, you can do a bony resection. So that is the resective osseous surgery, removing exoskeleton and tori. That is why I showed you the patterns of bone loss. Whenever there is an indication for resective osseous surgery, you write all the types of patterns of bone loss. It will be very easier for you to write the indications. Okay. So here, see here, this is a one wall defect, and this is a tori, this is a crater, so you can make it flat, and then this is a bulbous bony architecture. This is a crown lengthening where you lift the gingiva, do a bone cutting to increase the size of the crown for a prosthetic attachment. For correction of furcation involvement, you reflect the flap and then you do a resective procedure, right? These are all the indications. In which condition you don't do resective. Example, if a patient is having only 1 mm or 2 mm of bone, will you do a resective? If you do a resective surgery, the tooth will come in your hand. Okay, so if it is an extensive bone loss, please don't attempt to do a resective osseous surgery. If a patient is a high caries activity patient, please don't do a resective because you are going to reduce the bone height. Okay, the tooth may get shaky or mobility. And then existing mobility, already the tooth is shaky. If you do a resective surgery, again it becomes more. How will you grade mobility? Grade 1, grade 2, grade 3. Slightly more than normal, moderately more than normal, severely more than normal. In any sort of mobility, please don't try a resective osseous surgery. That is contraindicated. Again, in anteriors, aesthetic zones, it is contraindicated. Okay. So treatment planning, what you do is whether there is a sharp margins, take your fingers, run on the gingiva, check for any sharp tips or something like that, any ups and downs, any bulky bones, any tori, the soft tissue palpation. With the X-ray, you can see the craters, that's the projections, irregular bone margins, vertical bone loss, everything we can see. Furcation involvement, everything we can see with the radiographs. And then probing, just take the probe, run it along it, on the buccal side. One side is 5, mesio buccal is 5 mm, mid buccal is 7 mm, distal buccal is 9 mm. What type of bone loss it is? 5, 7, 9. Angular bone loss. If all the sides it is 5, 5, 5. That's not the bone loss. Very simple. So you check for the transgingival probing. That is, you check all the 6 surfaces. If all are equal, then there is a horizontal. If one side it goes down, then it is a vertical bone loss. Okay. So here you can see the vertical type of bone loss, soft tissue palpation, radiographic finding, and probing. So the armamentarium, what you use for resective osseous surgery. The one is bone ranger. Have you seen a bone ranger? It will be like an extraction forceps. It will have a clip on in between. You can just crush the bone with a bone ranger. And then the files. There are 2 types of files. One is a Sugarman file and another one is Luger file. For marginal bone as well as the interdental bone, you have the files. And then bone chisels can be used to resect the bone. And then burrs, surgical burrs, it is HP8 and HP702, and then diamond burrs. So you can see here, these are all bone ranges. The burrs HP8, that's a round one. Bone chisel, Luger file, Sugarman file, these are all the armamentarium. Okay, so in resective osseous surgery, you should write a definition, you should write an indication, you should write a contraindication, and then the armamentarium after after the armamentarium, everything is ready, what you are going to do? Surgical procedure. So what you do is give anesthesia, okay? Right? So you give local anesthesia and then incision and flap reflection, and you do the resective procedure, suturing it up and post-operative instructions. So we are going to do a procedure called resective osseous surgery. So this slide I want everyone to take it up. It's a very, very important slide even for the viva as well as for the exam. Your marks will stand for this. Okay? If you write all the 4 steps, minimum 2 marks you will get it. In just write these 4 steps, you get 2 marks. Okay? Right? So it's a vertical grooving, radicular blending, flattening of interproximal bone, gradualizing marginal bone. Okay? Right? So we'll see the vertical grooving is you perform with either a round, carbide or diamond burst to reduce the alveolar thickness. Okay, so vertical groove means the direction will be from the vertical. It is not horizontal cut, it's a vertical cut. Like when you make a tectorimation grooves in prosthetic crowns, right? It will be like that. You make a vertical grooving and then you just connect those grooves. That is called as radicular blending. You just smoothen the blending of the marginal or radicular bone. Okay, so grade 1 and 2 vocational environment are treated with both vertical grooving and radicular blending. Okay, so what are the 4 steps involved in resective osseous surgery? Vertical grooving, radicular blending, gradualization of marginal bone, flattening of interdental. So the third one is flattening of the interproximal bone. So what you do is you use a Schluger or sugar band file, go into the interdental areas, just smoothen the roughened edges. Okay, that is interdental bone, and then gradualizing the marginal bone. That's the final step. After you finish up all the 3 sides, just smoothen it. Okay, so these are the 4 steps which are very much involved in resective osseous surgery. Okay, so here widow's peak. There is a question. What is widow's peak? Okay, it allows the patient to rise a high level there. So widow's peak is something which is an irregular bony surface. When you do a resective osseous surgery, if you leave some very sharp tips or sharp margins, after closing the suture, that sharp tip will impinge on the gingiva, creates an ulcer, or it is very difficult to maintain it. The pocket will form very fast. So whenever you do a resective osseous surgery, gradualization of the marginal bone, that is smoothening around the crown, is very, very important to avoid the widow's peak. Widow's peak is a sharp part which has been left after the resective osseous surgery. Okay? So this is the 4 steps involved. It is vertical grooving, radicular blending, and then flattening the interproximal bone and gradualization of the marginal bone. Right? So healing after resective surgery is initially everybody will have an inflammation response, then necrosis of the crust, and then osteoclastic resorption, then bone remodeling to a smooth surface. So these are all the things healing after resective osseous surgery. So what is the disadvantage of having a resective osseous surgery is, one, you can result in gingival recession because you are going to smoothen or you are going to reduce the bone height. So there may be a gingival recession. Because gingival recession is there, what is going to get exposed? Cementum. So the patient will result in hypersensitivity. The tooth crown ratio, the tooth bone support may be varying because you are going to remove some amount of bone. Chances for a root caries because cementum is getting exposed. Maintenance will be very difficult because if you do a resective osseous surgery, the gingiva is going to go down. There may be a black triangle in between 2 teeth. So the maintenance, food infection can occur very easily. Okay. So the bypass questions are: what are the steps involved in resective osseous surgery? What are the steps involved? Vertical grooving, radicular blending, flattening of interdental bone, gradualizing marginal bone. There is some question called as spheroidy. Some examiner may ask you what is spheroidy. Right? It's a removal of a supporting bone to get a positive architecture. Whatever the procedure you do to get a positive architecture is called as spheroidy. Right? So what is positive architecture? Interdental bone will be placed more coronally, marginal bone will be slightly apically. Okay? Scribbing. Right? Scribbing is you draw, you make a cut with the handpiece and then remove by the hand instruments. Is called as scribbing. Right? And then VSP, as I already told you. Right? So these are the very important 5 questions involved in the resective osseous surgery. So resective osseous surgery, what is the synopsis? Definition, indications, contraindications, armamentarium, surgical technique, healing after surgical technique, and then what are the drawbacks? Okay, right? So we'll move on to the next one. That's a very important topic again, regenerative. So here there is a defect, either attachment loss or bone loss. So there are four items, four parts which are useful in regeneration. What is the first one? Yes, very good. It is the epithelium. The light pink color is the epithelium. So epithelium can regenerate. Okay. What is the second one? Connective tissue. Very good. The connective tissue contains of collagen. It is contains of fibers. Okay. Gingival fibers. The fibers are made up of collagen. Okay. Right. What is the third one? Alveolar bone. Bone can regenerate. Okay. What is the fourth one? Periodontal ligament. So if it is a regenerative surgery, what are the four elements can regenerate? Very good. So we'll see one way. As the healthy condition, the bone will be 1 mm of shortage of CEJ. The interdental papilla will engulf the area. It will be healthy. In case of periodontitis, there will be attachment loss and bone loss. Define chronic periodontitis. Anyone? Define chronic periodontitis. It is an infectious disease resulting in inflammation of the supporting tissues of the teeth with progressive attachment loss and bone loss. What is gingivitis? Inflammation of the gingiva without attachment loss and bone loss. So in gingivitis there is no need to regenerate everything. But in periodontitis there is a loss of attachment as well as loss of bone. So what you have to do? You have to regenerate. Okay, right? So we'll see one by one. So regeneration, as I told you, it is the regeneration of the cementum, alveolar bone, periodontal ligament, and epithelium and connective tissue. So these are all the defects once you open the flap. There is a defect. You give anesthesia, open the flap. You see like this. After removal of the granulation tissue, there will be a big hole inside. So what you have to do? You have to regenerate the last periodontium or tissues, whatever it is, you have to regenerate. These are the conditions where you can see one wall defect, two wall defect, furcation involvement, recession, all the things you can regenerate. So the regenerative, I want everyone to take this slide. This is very important. If this is an essay, you have to write all about these things. So there are three types of procedures we can use for regeneration. Okay, one is graft-assisted procedures. So you are going to put something, material taken from somewhere outside, and you are going to put it inside to regenerate. Example, you just think that you have a huge hole on the any flat surface. You are going to fill that space. So what you are going to do? One is graft-assisted procedures. So you are going to put something as a graft. The second one is non-graft-assisted techniques. Without putting any graft, you are going to do something else. And then there are advanced techniques. We'll see one by one. First is you have to have grafts, you have the membranes, graft plus membranes, everything. So the bone grafts, right? Bone grafts again is a very commonly asked short notes for everyone. Okay, even in the Viva question also, and these are all has been taken for you. This is just a revision before your examination. I just wanted to give a brushing of this, right? So the bone grafts, the synopsis again. This slide is very important. Definition of a bone graft, classification. Indications for putting a bone graft, contraindications, how you are going to procure, what are the uses of bone grafts, and conclusion. So bone graft means you have to write the definition of it, classification, indications, contraindications, and then the procedures how to procure the bones, right? So the definition, you all know, it's a biomaterial which is a characteristic of a living bone tissue that has been surgically inserted. The surgical name indicates that you are going to give an anesthesia, reflect the flap. Then only you can put a bone graft. Without reflecting the bone graft, you cannot put a bone graft. Okay, without reflecting the flap, you cannot put a graft. So that is what the surgically insertion word is very important. You are going to insert surgically something into the defective area. So the classification of the bone grafts is based on origin, mode of action, and bioresorption. So tell me, how will you classify based on origin? Autogenous or autograft, very good. Allograft, very good. Xenograft, very good. Alloplast. So what is meant by autogenous graft or autograft? Taken from the same individual. That is, if I am doing a surgery for myself, I take bone graft from me only. Okay, right? What is allograft? Same species but different individual. If I do a surgery for myself, I take from the other person, let's say human beings. What is xenograft? From animals. What is alloplast? Plast means plastic. So it is an artificial or a synthetic material which mimics the graft material. It is not a living tissue or it is not a, just a. So the ideal properties of a bone graft: it should not be non-toxic, it should be non-antigenic, it should not create any infection, it should cause an adequate bone fill, and one more thing is it should be cost effective also. Which is the least cost effective? Autograft, because it is taken from ourselves. So we are giving permission, okay, take the graft. If the same thing you are going to buy, then it is going to cost you. Now grafts are all 7,000, 8,000, 10,000 already. If you take your own body cells, it will be more cheaper, so cost effective. Okay. So classification based on action. If you put a bone graft, there are three main actions of grafts. What are they? Osteogenesis, osteoinduction, and osteoconduction. Osteogenesis means it's a synthesis of new bone from cells derived from the grafts and bone cells. So the osteogenic potential means if you put something inside, it will turn into bone. That is osteogenic. Osteoinduction means whatever you put it inside, it won't change into bone. It will just induce the adjacent cells to form the bone. It does not convert into bone. Okay, right? So that is osteoinduction. Osteoconduction means it will stay there. It will allow the adjacent cells to conduct through that grafts and make a bone. It does not again convert into bone. Even for years also, if you put the bone graft, if it is an osteoconductive, it will only conduct. It does not have any chance of growing as a bone. So the ideal gold standard bone graft is osteogenic potential. The bone graft which has an osteogenic potential is the ideal bone graft for all recessions or all defective areas. So based on the action, these are all the four different type of grafts. Triple plus is a very effective one. So which has got all three plus? Autograft. So it has got an osteoconduction, osteointegration, osteogenesis. So this graft is having all the plus. So this is the ideal gold standard bone graft material. Next to that, if you go for it, you can go for an allograft. That is same human beings, it has been taken from the other individual. That is the next option. The third option is xenograft. The last option is alloplast. Even though alloplast is comparatively cheaper, okay, but you should keep it as a last option. Whenever any chance time comes, you should go for autograft, right? Okay. So the classification based on the source, as I told you, autograft is taken from the same individual, same species, the animals, and then synthetically. In same species, you have two types of graft: freeze-dried bone graft (FDBA), and then another one is demineralized freeze-dried bone graft. Okay, so DFDBA. So the allograft can be divided into two, right? And then xenograft, either it can be derived from bovine. What is bovine? Porcine is pig. Bovine is bobo cows. Okay, right? Bobo, and then equine is horse. Okay, so you can take grafts from these statements which are very closer to the human ideations. Okay, right? So porcine, bovine, equine. Okay, and then there is something called as some living organisms, coral derivatives. Pavlapara, you have heard about it, which is under the sea, it will be there. It's a living organism, you can take it and use it as a. So that also considers, because it is growing, you consider it as an animal like that. Okay, right? And then the xenograft system, and then alloplast is from synthetic materials, that is chemical mediated materials. So these are all the things you know. Autograft, where and all you can procure autograft. If it is the same individual, from which areas you can procure is, one is either from the chin area, exostosis, ramus, tuberosity, any extracted sockets. Okay, you can take intraoral sources of autograft. Very important while purpose. Okay, if examiner comes, he is asking about bone graft means. The next question you will go to ask what are the sources of intraorally. So chin, exostosis, ramus, tuberosity. Extraoral is iliacus, tibia, fibula, ribs. Allograft is you have to take it from the cadavers. Okay, right? And then xenograft is bovine, porcine, equine, and chemically mediated are hydroxyapatite crystals, calcium phosphate, beta tricalcium phosphate, bioactive glass, and synthetic glass materials. So based on the bioresorption, there is something called as, if you put a bone graft, Either it has to get resolved or it has to get non-resolved. So fast resorption means it will take 8 to 10 weeks. What is the normal formation of bone? If you have a fracture in your hand, how much time it will take to heal? 4 to 6 months or 6 weeks? What is the normal bone formation time? 4 to 6 weeks or 4 to 6 months? Months. Normally it starts from 3 months, right? So the same thing, if you put a bone graft inside, okay, it will take minimum that much of time to convert into bone. As I told you, which type of graft is converting into bone? Only the autograft. You cannot expect, if you put a xenograft, you cannot expect bones to open after 6 months, there will be a bone. It will be only a osteoinductive or osteoconductive. Only the osteogenic potential only will be there as a bone. Okay, right? So based on the resorption, it is fast resorption material, slow resorption material, non-resorbing materials. So what are the methods of autogenous bone graft? How will you collect? You said from the intraoral, right? From where you will collect? From which part of the intraoral you collect autograft? From the chin, okay, from the tuberosity, from the tori, from the exostosis, from the extracted sockets. How will you collect this? You collect the bone. Okay, you either with the use of a bird or you can use a scrapers, remove the bone, mix it with the blood and use it as a graft. That is called as osseous coagulum. What is osseous coagulum? Bone dust mixed with blood. Okay, it's a bone you remove from the mouth and then you powder, the powder will be mixed with the blood and then you put it in the defective area. That is called as blood coagulum. Bone blend. You take a block graft or a piece of bone, take a mill. Okay, in olden times, party used to do tuck, 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 one petty will be there. Like that, there is something called as a bone mill. You take a piece of bone, put it inside, nicely chop, then you mix it. Okay, that is called as bone blend. Okay, right? So either a bone dust can be used along with the blood, or bone pieces can be used. That is called as bone blend. Bone swaging is you open the flap, the bone is exposed. Just take a chisel, just tap it and then push it. Without removing the graft itself, you just push the material to the adjacent area. Okay, in case one tooth is missing, you have a distal pocket of the previous teeth, just place the incision, push it towards the defective area. That is called as bone swaging. Okay, right? See here, this is the osseous coagulum where you remove the bone, take a drill, take the bone, mix it with the blood and then use it on the defective area. This is bone swaging. See, there is a distal pocket is there on 7. Take a chisel, cut it and then you can push it so the bone piece just move towards the bone. This is bone swaging. And then these are all autogenous bone grafts can be taken with a trephine. Trephine is an instrument where like a drill for a metro or when you put a bore, you put one metal rod inside the handle, that is like a bore. So these are all called as trephines. So what you do is, it will attach in a contractile handpiece, just put it on the bone graft, it will go, it will pick a bunch of bone inside. Okay, and then you release it and then you put it in the bag. So you can use a trephines for collecting the bone. Then scrapers. Scrapers is a machine like a shaving blade. It will be like a blade. So you have you seen how they make potato chips in bakeries? What they do? They'll keep they'll just see all the thing. The same thing here. So scrapers, you keep it on the bony surface, you just run it, and then bone will come in that. Okay, so scrapers, trephines, chisels, burrs, these are all the instruments which are used to collect the autogenous bone. Okay, and this is a chin bone. Okay, this is called as bone crustal. Okay, it will be like a Krishna Paramatma Chalni Chakra. So if you just run it on the tooth, it will cut on all the 4 sides, remove the bony chip, and then go to grandmother's itchifying, put a bone blend. Okay, so this is called as bone crustal, right? And then extraoral sources, you can take it from the iliac fossa or you can take it from the tibia. You take it and use it. Then allogenous grafts, same species, different person, obtained from cadavers within 12 hours of death. Okay, because the viability of the tissues will be dying after that time. Okay, so this is the very important. And then you process after acid etching, alcohol washing. There are so many procedures. After that only it comes to the market. You remove the antigenicity. If the patient is having an HIV or something like that. Sometimes the drug can get transmitted. So to avoid that, there are some procedures. After that only it comes to the market. So please don't worry about the thing because this is the next option. And then it can be either freeze-dried bone graft or demineralized freeze-dried bone graft. Okay, right? Allografts, it comes in a powder particle size. Okay, take it. It is available in the market. Maybe 5,000, 7,000 rupees. Just buy it, put it in the DVD. The patient does not want a second stage surgery. Okay. So xenografts, from where it is derived? Calf bone, bovine derived, porcine derived, equine derived. Okay. So bovine, porcine, equine, and then some of the coral tissues also considered as xenografts, as I told you, right? Then alloblast is synthetically driven calcium phosphate, bioactive glass materials, which is purely silica particles, aluminum particles, like that, and then coral derived materials also. Some of the different types of materials will be available. So alloblast available as these brands. Okay. So the main thing is calcium phosphosilicate, bioactive glass, beta tricalcium phosphate, and hydroxyapatite. Okay. So what are the four types of bone grafts? Autograft, allograft, xenograft, alloblast. What are the intraoral sources of autografts? Chin, ramus, tuberosity, torrent, exostosis. So this is the two questions you get it in Viva. If it is in the short notes and the question paper, you have to write what is a bone graft, how will you classify bone grafts according to the source of origin, source of bioabsorption, okay, and then source of action. And then write about all the bone grafts, how you are going to calculate. And there is something called as, you take a bone graft, you mix with some biological mediators for better regeneration. What you can mix along with this is, you can do something called as PRP. What is PRP? Platelet-rich plasma. From where you take it? From our own blood. So anticubital fossa, take a blood, put it in the centrifuge, run it, and then get a PRP. Okay. If it is a membrane, then it is called as PRF. Platelet-rich fibrin also can be used. And you can put a lot of growth factors along with this. Platelet-derived growth factors, bone morphogenic proteins, right? So this is PRP. Okay. You can take it from the bone and then mix with the bone graft. You can put it in the defective area. This PRP contains more amount of growth factors. You know growth factors, right? What is PDGF? Platelet-derived growth factor. What is FGF? Fibroblast growth factor. What is TGF? Transforming growth factor. Okay. What is IDGF? Insulin-derived growth factor. So these are all some growth factors which are present in the body cells, blood vessels. Okay, bloods. So it can be used along with the bone graft. So take a bone graft, you modify it. Okay, like dosai. What is the modification you have to make in dosai? Rava dosai, masala dosai, ghee dosai, podi dosai, onion dosai, onion rava dosai. So same thing you can do a regenerative material along with the bone graft. You can make so much of variations. You can add this bone, this factor, that factor, this factor, like that. Okay. So a regeneration can be very helpful. You can place all these types along with the bone graft, and which will be helpful for the periodontal regeneration. Okay. So non-graft associated procedures. So here we don't use any bone graft. Okay, what do you do with this? So here there is something called as GDR, LANAP, and combined techniques. What is GDR? Guided tissue regeneration. That is, either it can be a non-resorbable or resorbable, and then LANAP. What is LANAP? Laser assisted new attachment procedure. Okay, right? And then combined techniques we'll see. So what is GDR? Very, very important Viva question. What is GDR? Okay, if there is a defect, you don't put any bone graft there. You keep a membrane. You place it in between the alveolar bone and the gingiva to prevent the downward growth of the epithelium. Here the epithelium is present. If you don't keep a membrane, the gingival epithelium will come down and fill this area. That is called as long junctional epithelium. It's a very, very soft attachment. Again, infections can come in a long junctional epithelium. To prevent that, you keep a membrane. So after you keep a membrane, what will regenerate here? Periodontal ligament and alveolar bone. So we want that one only. The periodontal ligament attachment is the firm attachment. So you should keep the space. Otherwise, junctional epithelium very fast go inside. Okay, right? So you should be able to do that. So have you seen ginger oil, okay, castor oil and all? You have seen ghee, right? Once you put it in a pot, which will dry very fast. Ghee or normal coconut oil or ginger oil? Ghee, because once you put a ghee in the broth, you have to act very fast. If you are going to roast cashew nut, you put ghee and then you wait for 5 minutes. Only the stove and only the pot will be there. Ghee will be evaporated. So the faster action, the epithelium tends to grow faster than the periodontal ligament. So that is why we are putting a membrane in between the gingiva and the bone to keep a space for periodontal attachment. Okay, right? So that is called as GDR. If it is a GBR, you are going to place a bone inside and then cover it up with a membrane. So what is the difference between GBR and GDR? In GBR, you are placing a bone graft, on top of it membrane, suturing. In GDR, you are going to only guide the tissue. What type of tissue you are guiding here? Epithelium. You are preventing the long junction epithelium. Understood? So barrier membranes, very important classification. These are all ideal membranes as usual. Like observable, it should be observable, biocompatible, it should create a space, it should have an easy adaptation. And this slide is very important. How will you classify membranes? These membranes are very commonly asked as short notes and it's a viva question also. So how will you classify membranes? First generation, second generation, third generation. First generation is non-resorbable. Second generation is resorbable. Third generation is resorbable with growth factors. Okay. So non-resorbable means it won't resorb. You have to do a second stage surgery to remove the membrane. Understood? So whatever you are going to put it is not going to resorb. So there is a defect. Okay, you put either a graft or without graft also you place a membrane, suture it up. After 2 months, again you have to give anesthesia, open the flap, remove the membrane. That is called as non-resorbable. Resorbable means it will absorb on its own. Then resorbable with growth factors is the third generation. Now people are using only third generation. Lot of people doesn't use first generation because you need a second surgery. Okay. So here first generation membrane, EPTFE membranes are the most commonest ones used previously. Okay, those are all non-resorbable membrane. Or titanium is also non-resorbable membrane. So you give anesthesia, open it, put a bone graft or a membrane on top of it. You just place a titanium mesh. After 2 months, again give anesthesia, open up, remove the titanium mesh. So titanium mesh and the EPTFE membrane are all non-resorbable membranes. That belongs to the first generation. Okay, it is available in various sizes, shapes. According to the defective area, we can put that. Okay, right? So the second one is resorbable membrane. What are the resorbable membranes available are? Collagen membrane, Gargle membrane, polylactic acid, oxidized cellulose, and bicameral periodontal mesh. These are all the resorbable membranes. Okay, so what is the first generation of membrane? Second generation? Third generation? Tell me some growth factors. Insulin dependent growth factors, fibroblast growth factor, transforming growth factor, platelet, these are all growth factors usually. Okay, everything can be added on the membrane also. It can be added on the bone graft also, it can be added on the membrane also, right? Always put some extra spice means it will be useful in faster regeneration. Okay, understood? So commercial available membranes are, there are them same, BioGuide, Collaguide, DD-Guide, so many guide membranes are. Okay, available in different shapes. Internally area also you can place the membranes. The third generation is resorbable and antimicrobial, resorbable with growth factors. Okay, right? So LANAP is laser assisted new attachment procedure. So what do? You can improve the periodontal regeneration by removing the smear layer. Example, if there is a pocket depth of 8 mm, it will be covered with a granulation tissue. Okay, right? So what is your name? Surrounding, yes. So imagine that there is a tooth, there is a 8 mm pocket, surrounding is standing straight inside the pocket, base of the pocket. These are two sides. One side is the soft tissue lining of the pocket, another side is the hard tissue lining. So what will be present in the hard tissue? Bone. No. You are inside the pocket. On your right side tooth is there. What material? True cementum. In that what all will be present? Subgingival plaque, subgingival calculus, necrotic cementum. Everything will be there on this side. What will be there on the other side? Tissue side. Granulation tissue. It contains bacteria, bacterial toxins, neutrophils, macrophages. Everything together is called as granulation tissue. So there is a granulation tissue which is keep on touching the root cementum. So there will be lot of bacteria will be sticking on the wall of the cementum. You have to remove that wall. Then only your attachment will be fine. Otherwise, if the bacteria still stays on the tooth wall, you cannot have an attachment. Periodontal ligament cannot come and form. The bacteria will be there. It will keep on releasing toxins. So what you should do is, in the laser, you are applying it on the tooth surface or on the gingival surface to remove the granulation tissue or the necrotic cementum, the smear layer. So that using the laser, you are doing it. With the curette you do, then it is called as curettage, or otherwise if you create a new attachment, it is called as inap. Have you heard about the inap? Excision new attachment procedure. In that you use a curette. If instead of curette, if you use laser, it is called as lena. Okay, right? So it helps in periodontal regeneration. Here you can see the pocket there. You take the laser, apply a photosensitizer, you present both the sides. You can the tooth surface also you can do, remove the smear layer, make it perfect for periodontal regeneration, and to do it on the gingival side. Again the cells will proliferate, growth factors will be proliferating, you get a good attachment. That is called as LANA. Okay, so this is a and then root biomodification. Again, this is very important short note. Okay, normally 90% of the papers either will have a membrane or a graft or a root biomodification. Either of these three, one question definitely will be there in your question paper. So what are the things is very important for root biomodification? Citric acid, EDTA, fibronectin and tetracyclines. Okay, so these are the four root biomodification agents which can make you help in better adaptation of the tissues for periodontal regeneration. These four are very important for root biomodification agents, right? So this is EDTA, okay? EDTA, then these are all available in gel forms. So after your SRP, you apply this on the root wall so that it will act as an agent which can cause pores in the cementum wall, so that the fibers from the periodontal ligament can go very deeply attached, so that you get a better regeneration. Okay, citric acid, right? And then EDTA, right? It's a irritating agent. Tetracycline capsule. How you do is buy a capsule which is 1 rupees or 2 rupees. Open the capsule. Inside the powder will be there. Put it inside. 1 ml of saline or something like that. Just put a small drop of saline. Mix it. Take a cotton. Just dip it and then rub it on the root surface. Okay, so it will act as a cleaning agent. It will make minute pores on the cemental surface, so that the attachment will be very nice. If you are doing a painting on your whole house, first what the painter will do? He will scrape the wall to remove all the old cement, paint, everything. Then only the new will stick nicely. Same thing what you do for the periodontal regeneration, you attach. So for the betterment of the attachment, you use agents called root biomodification agents. What it will do? It will make a smear layer or make minor pores, so that the regeneration will be very good. Okay, so these are all the growth factors which are very, very important for the regeneration, as I told you, right? So PRP is a soft, PRF is a membrane. PRF is a membrane. You can use it for recession coverage and all. Okay, these are all the membranes which can be used for periodontal regeneration. Then Emdogain. Okay, Emdogain is a protein matrix which is present in the 6-month-old baby. It is present in the dental follicle. Okay, for this we have to sacrifice the animal and then take it. Okay, and then you can use it as an adhesive material for better regeneration. Emdogain. Okay, GEM21S, that is growth factor enhanced matrix. Right, this is the tissue engineering which we will be using. It's a bioactive protein which can be helpful in periodontal regeneration. GEM21. Yes. And then peptide, that is, it's a peptide, okay, right? It's a tissue engineered bone replacement graft material. It is an artificial material, reflects like a normal bone, but it has got induced of a peptide which is better for periodontal regeneration. Okay, these are all other biological mediators which are helpful in periodontal regeneration. And then the last question will be the tissue engineering. What we are going to do with the tissue engineering? Okay, normally in petrol, they will say it is a chemical engineering. So there are so many factors which involves engineering, plastic engineering, leather engineering, marine engineering, naval. So what are the department it shows? It is attached to the engineering. Here we are doing a procedure on the tissue. So this is tissue engineering. What are the 4 components of the tissue engineering? Cells, scaffolds, signaling molecules, blood supply. For everything you need a cell. For a regeneration of a cell, what cell is required? For a periodontal ligament it is fibroblasts. For a cementum it is cementoblast. For a bone it is osteoblast. For a epithelium it is starts with K. Very good, keratinocyte. So if the cells are very important for the regeneration, so the cell series. Scaffolds you know, right? There are two types of scaffolds. One is graft material, another one is membrane material. What are the scaffolds here? What are the membranes? How will you classify membranes? Non-resolvable, resolvable, the growth factors. Signaling molecules, okay? What are the signaling molecules you know? Okay? Signaling molecules are the growth factors, right? Chemical mediators. And then blood supply should be ideal. Blood should be there present for healing. If there is no blood, no healing. Okay? Right? So these are all the sources where we take it from the extracellular matrix proteins. Okay, from the body, these are all can be taken. And then these are all periodontal ligaments. You can take a periodontal ligament stem cell. Okay, and then process it and then keep it inside the defective area for better regeneration. Right? So cells, scaffolds, okay, signaling molecules and blood supply. Please remember these four. Okay, for the tissue engineering. Combined techniques, these are all uses enamel matrix derivative alone with the coronary advance plaque, moderate to deep pockets, EMD with the graft with coronary, EMD with always graft and membranes are plays a major role in regenerative periodontal surgery. Right? So periodontal regenerative therapy, root biomodification should be done, wound sterilization should be done, prevention of the downgrowth of the epithelium should be done, presence of predehiscence are for all four together contribute for better periodontal regeneration. Okay, so the take-home message for today is the successful periodontal regeneration depends upon the patient selection. What does it mean, patient selection? A patient is a smoker. Will you do a periodontal regeneration? Does not become because of excess heat will kill the cells. So uncontrolled diabetes mellitus. Will you select him for the surgery? Once you keep a very huge amount of bleeding, will be there. Delayed wound healing, no growth factors, no stem cells. You should be very careful. Patient selection. If it is a non-compliance patient, he is not going to brush at all. Will you do a flap surgery? Will you do a regeneration? You are going to spend 10,000, 15,000 for a bone graft. 1 week the graft will be failure. Patient will come and say that you have made a fault. But the next day you have gone through a smoking. If it is a non-compliance patient, there is no point in doing a periodontal regeneration. So patient selection is very important. And then surgical technique. Now this comes to you, right? As a normal dentist, everybody can perform the regenerative procedures, but you should have a good knowledge about the defect, size of the defect, what material can be best for this defect, okay, from where it can be taken. So the surgical technique is very important. Overheating, wrong incisions, tearing of the flap, these are all very careful. And then proper debridement, graft and membrane placement. Suturing is a very important role. Whenever you place a bone graft or a suturing, that should be covered under the gingiva. Okay, don't make it exposed. If it gets exposed outside, it will go for a failure. Okay, and then post-operative injections and maintenance. Post-operative injection, nothing hot for 1 day. Okay, keep ice fermentation, nothing gargling. Okay, don't disturb with the tongue or fingers. Regeneration will take more time. If you put a suturing, you go for observable sutures because it will take 80 days, 90 days, or 3 weeks for a resorption. If you put a silk suture after 5 days, you remove it. Inside bone graft won't be resolved or formed at all. So all bone graft will come out after 1 week or 10 days. So you should know that suturing what kind of place for. Okay. So again, the first slide I put it last. What is the problem question here? Resective osseous surgery, definition, indication, contraindication, steps involved in it. Regeneration, bone grafts, autograft, allograft, xenograft, alloblast. Membranes, first generation, second generation, third generation. GTR, only membrane to put it. GBR, along with the graft membrane. Root biomodification agents, citric acid, EDTA, tetracyclines. Tissue engineering, cells, scaffolds, blood supply, signaling molecules. Okay? So I thank Tagore Dental College for giving me this opportunity, and this is my student Periodarshan Dental College. And thank you all for your peaceful listening. Okay? Any doubts, regeneration, resecting? These two are very important questions. In your question paper, either resecting will be there or regenerative will be there. Definite 10 marks from this session. Okay, right? Yeah. Thank you so much.
Thank you so much, sir. That was a very detailed and keyful lecture. I think almost all the key points are covered in sir's lecture. It's wonderful notes for you all to take down and use it for your exams. Now I request Dr. Narasimhan sir, Professor from Prosthodontics, to felicitate Dr. Kadiresan sir with a memento and certificate.
last 2 days we have been having various topics, right? So on the topics என்னென்னலாம் வந்து like surgical point of view நீங்க வந்து பாத்துட்டீங்க. What do you like previous lecture from previous lecture what you can tell? You can do regenerations, you can add the different types of grafts, you can do different types of incision and all that, you can use lasers, okay? So you can do multiple things. Perio is not about scaling and root planing only, okay? So that you have to understand. How many of you are going to be a clinician here? So our aim is all of us wanted to be a clinician, right? So to become a clinician, if you are knowing perio in detail, it is enough. Okay? So you can manage cleaning very well. So let's move on to this thing. I thank Tagore Training College and the head of the department, Dr. Bhuvaneshwari ma'am, for giving this opportunity, and for an undergraduate, the rapid revision course, so it is really helpful. So I have seen institution taking the rapid revision course for PG, but for an undergraduate, your college, they have been doing it, very consecutively, and it is very helpful for you people. So I thank again the Tagore Training College management as well as the Department of Periodarshan. So this is the college where I belong to. I did my UG here, and I got into this college as an assistant professor, so I am very grateful for it. So this is the team where I belong to. It is headed by Dr. Jaideep Mahendra ma'am. So she was the one who gave me this opportunity to talk to you, so on, to explain things about my topic. So this is Dr. Anupama Rajapalli. So she is my mentor and guide. She was my guide in post-graduation. If I am very confident about my skills, if I am very confident about my subject, it is because of her. I am very grateful to her. So yeah, now we all know what is the topic for today. It is what? Gingival recession and its management. So myself, Dr. Periodarshan, I am an assistant professor from Department of Periodontics and Implantology. So these are going to be the contents which I am going to discuss today. So when they are going to ask as an essay to you about gingival recession, this is the content. So everything will be there in this content itself. So introduction, we will be discussing about definitions. So what is gingival recession and all that we will be discussing in the introduction. And then etiology. How does the gingival recession happens? So we will be discussing that. And then there are any number of classifications. So you don't have to memorize or mug up all the classification. I'll just explain 3 important classifications. Adu therinjale, it is more than enough for you. If you write it in the paper, that is good. Okay? So, and then I'll tell you about clinical features. What happens if you get a gingival recession? Okay, that is there. And then how you will diagnose gingival recession. So most of you can appreciate a gingival recession, but you will not know how to diagnose. So what are the different classes? How to diagnose, you will not know. So and then what are the factors which can affect the treatment outcome? So you have identified a gingival recession and you are going for a treatment, and you should know what all factors can affect the treatment outcome. And finally, what are all the treatments are there? So that will be seen. Okay. So what is gingival recession? Gingival recession is yes. So it is displacement of gingival margin apically to the CJ. So gingival recession has happened. So gingival recession another. So what we will get it? So what happens when we have a gingival recession? So there is going to be a loss of periodontal connective tissue fibers. That will be along the root cementum. So finally, in which area you can see a gingival recession more commonly? So it is more commonly in the labial or buccal surface of the teeth, and it is one of the most common aesthetic concerns. Okay, so in the anterior region, if you got a recession, definitely it is one of the most common aesthetic concerns. So this is the introduction. And then etiology. So what could be the causes to get a gingival recession? The first one is what? Abrasiveness, too much of abrasiveness and trauma while brushing. So So, like ma'am had discussed previously, you have got different brushing techniques. If you are doing an improper brushing technique such as scrub method and all that, and if you're using too much of abrasiveness, you are definitely going to get a gingival recession. And then, if the patient is having any periodontal inflammation, cold plaque control, and all that is going to be a cause for gingival recession again. And then frenal and muscle attachment. So here you can see a lot of tensions are there in this picture. So that is the reason. And then orthodontic too much of force, what will happen? So it will cause bone loss and eventually there will be a recession. So this explains in detail. So brushing technique, like I said, horizontal brushing technique or incorrect method as well as dental instrument. You will be doing a hand scaling, right? So if you are handling an hand scaling instrument, so improper technique. That is why we always emphasize on the principles of instrumentation. You will definitely need to know what are the principles of instrumentation and the proper technique to correct the angulations. So under periodontal disease, chronic inflammation and infection due to poor plaque control. Anatomic factors. What are the anatomic factors? So in our Indian population, so what do you think are gingiva? So is it thick or thin? Indian population gingiva எப்படி இருக்கும்? thin ஆ இருக்குமா இல்ல thick ஆ இருக்குமா? Sorry? No. So the Indian population will have very thin phenotype. Okay. So that is one of the reasons. And then frenal attachment. So if the patient is having high frenal attachment, so that is also one of the reasons. And then systemic factor, environmental factors. Systemic factors like diabetic patients. If the patient is diabetic, definitely at some point he is going to have periodontal disease. So that is one reason. And then smokers are very commonly affected with gingival recession and hormonal changes during pregnancy and menopause and all that. If the patient is taking too much of contraceptives, definitely you can expect a gingival recession. That is there. Okay. So and then like mechanical factors, I have told you will have an orthodontic movement. So excessive orthodontic movement and piercing. Some people will get an excessive lip and tongue piercing and all that because of irritation. You will get a gingival recession. So you are going to do a surgery, mucogingival surgery or perioplastic surgery. Why you are doing it? So in a reason, what is the sole purpose that you are doing it? What you have to achieve it? So here there are three main principles. So one is you will have to maintain the existing keratinized gingiva, and with maintaining the existing keratinized gingiva, you should not expose the bone. And when you have an adequate zone of keratinized gingiva, so the vestibular drift is not a factor at all. So this is what, like I said, there are n number of classification. You will get this slide, you can read about it. But I will explain you about only three classification. That is first classification, Sullivan and Atkins classification. You would have read about it, Sullivan and Atkins classification. And I will be dealing about Miller's classification and what are the limitations of Miller classification. Okay? So and then third classification, what do you think? Yes, exactly, Cairo. So Cairo's classification. That is what we commonly use in most of the articles now. Okay? The first one is Sullivan and Atkins classification. So what are the classes that are there in Sullivan and Atkins classification? Shallow narrow, shallow wide, deep narrow, and deep wide. So even though this classification is very simple, so it lacks scientific evidence and objectivity. That is why it was got modified with the measurements. But also it lacks scientific evidence. That is why they went for Miller's classification. Who proposed this Miller classification? Miller. P.D. Miller. So at what year? 1985. So Miller classification with this separator, they might ask you for a short notes. So the first thing we should have to know is the author name and year. So and then he had proposed this classification in how many ways? 4 ways. So based on what? Evolution of soft and hard periodontal disease. Okay? So we'll see what are those classification. What? So you have to take mucogingival junction as reference in this all classification and interdental soft tissue loss. Okay? So in the first classification, what you have said? Marginal tissue recession. It does not, it's not beyond the mucogingival junction. Okay, that is the first class. So we said there is no periodontal loss or bone loss. So there is no going to be no not extend beyond the mucogingival junction and there is no periodontal loss. I mean bone or soft tissue loss in the internet area. So here he had stated that we can anticipate 100% root coverage in the class 1. Whereas in the class 2, what he had said? Marginal tissue recession that can extend to or beyond the mucogingival junction. Here what you can see is here also you cannot appreciate any what? Bone or soft tissue loss. So that is the thing. Here what you have said is here also you can anticipate 100% root coverage. So in class 3 what you have said? So here marginal tissue recession will extend beyond the mucogingival junction. Okay. So it will extend beyond the mucogingival junction. Whereas you will have an intermittent soft tissue loss also will be present. So here we have said 100% root coverage is not possible, but still partial root coverage you can get it. Why I am emphasizing edukkaga na the root coverage patti na basic irukku I'll be discussing about that the limitation part. So why this estimation of root coverage is not important. So I'll tell you that. So in class 4 again you will have a marginal tissue recession, it extends beyond the mucogingival junction. So here you will have a bone and soft tissue loss will be there and severe malpositioning will be there. So these are the 4 classes of gingival recession. So either proper so half the marks are there. Okay, for short notes. So like I said, so so they will find faults. So that is what, though it is very easy and simple classification and we have limitations, certain limitations. So we'll see what are the limitations. The first is we have taken reference point is what? We have taken in all the classification, what is the reference point? Mucogingival junction. So in most of the cases it is very difficult to identify what? Mucogingival junction. So that case, what they are saying is, so class 1, class 2 is very difficult to identify. So and then that in the other limitation they say intermittent bone or soft tissue loss is important, but he had not specified to what degree the intermittent bone or soft tissue is. Class 3 को intermittent bone loss or soft tissue loss is சொல்லிருக்காரு. Class 4 को வந்து he had told that. But to what extent? What is the severity of bone loss? He hadn't specified. So that you will not be able to classify if it's class 3 or class 4. Okay. So and then we have, so take this picture. So you tell me what class it belongs to. Did it extend beyond the mucogingival junction? So where is the gingival margin? Did it extend beyond the mucogingival junction? No. But does it got soft tissue loss and bone loss? Yes. So what? Since it did not extend beyond the mucogingival junction, do you call it as class 1? Class 1. You cannot call it as class 1. So you cannot call it as class 3 also. So you have this problem in it. Okay. So that is one of the limitations. And we did not specify facial or lingual involvement. Okay. That is there. And so recession of internal papilla alone cannot be classified as a separate recession entity. So that is there. And finally what? So parietal aspect. So he did not mention a recession which can occur in the parietal aspect. Parietal aspect of the recession but he did not mention at all. Okay. So then like I said, root coverage percentage. I have been discussing about this now in the classification part. Root coverage percentage. So what in literature they say is 100% root coverage is we will not be able to achieve 100% root coverage. In literature, whatever they have quoted so far, it is between 9 to 90%. So to be precise, like we have got in a systematic review and all that, 78% to 80% root coverage, it is achievable in most of the cases, like in class 1, class 2, that type of cases. So these are the certain limitations. See, if they ask about recession, definitely you have to include about pillar classification and this limitation should be there in the paper. Okay. So and then we have what? Kairos classification. Here also you should remember about the author as well as here. So you don't have to remember for every procedure. So at least for few important topics you have to remember the author's name. Okay. So what is RT1? So here this classification is based on the clinical attachment loss and buccal and interproximal. Clinical attachment loss in the buccal and interproximal. He had taken these two reference points. Okay. So So in RT1, what happens is, so there is no loss of interproximal attachment loss. Interproximal attachment loss will not be there. So recession will not be there in the interproximal area, whereas there will be in the buccal side, there will be an attachment loss will be there. So taking class 2, RT2, so here do we have an interproximal attachment loss? Can you appreciate an interproximal attachment loss here? Yes. So we have a buccal attachment loss? Yes. So you will have both attachment loss, but the interproximal attachment loss will be very less than or equal to the buccal attachment loss. This is what you have to get it, okay? So RT1 and interproximal attachment loss, because there can be a buccal attachment loss, that is in RT2, interproximal attachment loss will be there, but will be less than or equal to the buccal attachment loss. So whereas in RT3, what you can appreciate? Interproximal attachment loss is greater, exactly. So it's done, almost done, the classification is done. Here you can see the difference, okay? So like what I said, RT1, RT2 and RT3. Very simple, very simple, okay? You don't have to memorize or mark it up and all that. And then these are the clinical features. If you have got gingival recession, what happens? So first, if it's an anterior region, so aesthetic is very much in concern, and you will have a sensitivity to hot and cold due to what? If you are getting sensitivity, why you are getting sensitivity? Okay, so that is it. And then aesthetic concern, like I told you, if it's the facial aspect, you are going to get an aesthetic concern. So severe attachment loss. Severe attachment loss will lead to what? Deepening of periodontal pocket. So in that case, you are going to get a bone loss also and attached gingiva. So if there is reduction in the attached gingiva, there is going to be a poor scar control. If you get a recession, there is going to be a reduction in what? Attached gingiva. So upon this, you cannot maintain a proper oral hygiene. That is great. Diagnosis. How do you diagnose? First one is, when you see in the naked eye, you can see recession. That is one thing. Visual examination. Then with the probe. So with the probe, you will measure the gingival margin, and back you will take the reference as gingival margin. You will take the recession area, and then frenum. If there is too much of high frenal tension, how do you measure? What test you will do? Okay. So what do you see when you are doing this frenum test? Blanching. Exactly. So yeah, almost polymuscling gingival recession. So you have got, if they are had like you have got an essay for 10 months, so 5 months then. Okay, we have remaining 5 months to see only what is the surgical part and non-surgical part. So that is very important. We'll see that also. So apart from those visual examination and test and all that, we'll take radiographs. Okay. So mostly periapical radiograph is enough. In some cases, we'll take CBCT to see what? Bone thickness. What is bone thickness? What is gingival thickness? We'll see and we'll assess that. And then biotype. Like I said, thick biotype, thin biotype, and we will assess. Based on, we'll put a white probe inside, and there will be a transluminant area. If you are able to see that white probe, then you have what? Thin biotype. Good. So before going to treatment part, so we'll have to know what are the factors which influence patient selection as well as the treatment. Here we can divide those factors into local factors and systemic factors. Local factors na enna? We'll have to assess a Clark score. Why do we assess Clark score? Why Clark score assess pannom? Patient oral hygiene. So how he or she is maintaining their oral hygiene. So why are we doing that? Why ada pannom? We are going to do a treatment. For the treatment to get a good prognosis, what we should expect. Patient should have a good oral hygiene. That is why in every surgical procedure they take OHI index, Clark score, Debris score, reason on that is the only reason. And then whether the compliance with treatment recommendation is there with the patient, where patient can cooperate, so where he can just go ahead with whatever the recommendation we do, that has to be there. And presence of periodontal periapical infections. There should not be any infections in the source of infection. So before going to the surgery, it has to be eliminated. So that is there. And aesthetic concern. So we'll have to see at what region there is a recession. If it's an anterior region, if it's the posterior region. If it's an anterior region, we have to go for that type of technique which will not affect their aesthetic concern. Like ரொம்ப minimal invasive போகலாம், microsurgery treatments போகலாம். So அப்படியெல்லாம் போகும்போது we can even achieve root coverage also, as well as we will not compromise on what? Aesthetics. Exactly. So and then we have prosthetic device. You will have to see if the patient is having any dentures, or sometimes if the patient might have a partial denture where he can have a clasp. That clasp might impinge on the gingival margin. It can cause irritations. So that is there. So and then finally habits that affect the local tissues. You know what habits and all that which affects the gum tissues. So finally systemic factors, like I have told in the first few slides, diabetic. So if the patient is having a uncontrolled diabetic, definitely that patient is going to get a bone loss, or he or she is going to have a soft tissue loss. So and then if any immunodeficiency, things like HIV and all that, and smoking and areca nut chewing and all that is also a thing. So to manage gingival recession, we have two types of management. What? Non-surgical and surgical. Non-surgical, simple. We have seen the previous seminar about entirely about non-surgical. Ma'am had clearly explained to you what all the non-surgical topics are there. So in that, first thing is oral agent instruction. In oral agent instruction, what you will advise? Brushing techniques you will advise. You will advise electric brushing. You will advise different methods and all that you will advise. Okay. So very simple. Gingival recession கேட்டா நீ கண்ண மூடிட்டு வந்து உங்களுக்கு வந்து 4 பாயிண்ட் இருந்தாலுமே அத பத்தி நீ இவ்வளவு தூரம் வந்து நீ கதை எழுதணும். சரியா? So and then scaling and root training. You are done and dusted with scaling and root training. அவ்வளவு படிச்சிருப்பீங்க. So that is there. And then desensitizing agent. Fluoride varnishes like calcium phosphate will help to reduce the tooth sensitivity, and this main ingredient potassium nitrate. Have you seen this desensitizing paste or not? Most of the ingredient. Exactly. So all this is Viva topics also. They'll ask about this ingredient and all that. So and finally what? Fluoride. So we are using it right, left and center. Fluoride filter use panni. We'll have to reduce the inflammation process and all that. So non-surgical is done. We are going for a surgical management. Okay, va? Surgical management la there are these three things. Gingival graft. So gingival graft la there is FGG. What is FGG? What is CTG? What is the difference between FGG and CTG? FGG is something that you will take from a different donor area and you will give it the recipient side, and it has got what? Epithelium on it. So that is the thing. And carotid tissue graft, it is also taken from a donor area, but it does not got. Yes. So FGG we do it to increase what? Width of attached or to increase the keratinate tissue. And we keep CTG in most of the areas to what? Increase thickness. Gingival thickness. So you have to be very clear in these two things. You have to know what is FGG, what is CTG. Clear? So and then coronary position flap. What is coronary position flap? You will advance the flap from one area to advance the coronary and you will position it. Okay, CTG and everything you will advance it. So that is coronary position flap. Later pedicle flap. What is pedicle flap actually? I'll tell you. So before that, going for a surgical part, you should know certain terminologies. Okay, pedicle graft and so like ma'am had explained incision. You have known about incision. So incision, any type of incision you know. If you are very familiar with it, then it is very easy to know what technique wants what incision and what graft. Okay. So pedicle graft and so here the base is same. Like unlike FGG or CTG will not take from different areas. Here we will use the adjacent area where the base is going to be safe, the blood supply is not compromised, everything is going to be safe. Okay, so that is a pedicle graft. So if you see, patient has got recession in this side, they have taken this as the base and they have covered it. Okay, and then like I explained, you have FGG, free gingival graft, that you will know, and incision. So incision is what? External bevel is there, internal bevel is there, and releasing is there. External bevel na enna? Ma'am, external bevel, what is that? See, and this telling this thing for an understanding point of view. External driven will give incision facing what? Tooth surface. It will not face the bone. Okay? So just for an understanding point of view. Look at here. This is an external driven incision. Okay? This is an internal. What is this? This area, bone. And where are they giving? Internal driven incision. And this is internal and releasing incision or vertical incision, we all know. So why do we give vertical or releasing incision? For the flap to be mobile. Okay? So that is the thing. And full thickness and partial thickness. So what is the difference between full thickness and partial thickness? Full thickness is what we will involve. Yes, super. And in partial thickness, so periosteum will be, yeah, not involved. So definitely, so this is the last part. I will be covering those techniques. Okay. So just be attentive to know what are those different types of techniques applicable to recession. Now, what technique will go? Okay. If it's coronal to recession, now what techniques we have to do? Like I said, pre-gingival graft, that will be discussing what are the healing stages in the pre-gingival graft, that will be discussing, and then connective tissue graft and apical tissue graft. That is, if you want to do coronal advancement, what are the techniques are there? We have laterally positioned pedicle flap and coronal advanced flap, and then we have different pouch and tunnel techniques on all that. We will be discussing about all that. Okay, so if they ask you about the surgical management, this slide has to be there. Okay, this content has to be there in your paper. So like I said, so initially it was described by John in 1963, and there are different techniques. So you should know these four words. You should know. Particularly in detail, if you are not explaining also, you should know these four techniques. One is what? Classic technique. Another one is accordion technique. So you can see in this picture accordion technique and all that. Other one is strip technique. So other one is combination. Then sometimes we use combination of these techniques. Okay. So this is there. So classical technique. So from the classical technique, what you can appreciate from this picture. So they are taking tissue from where? Palate. So they are inserting the blade and they have seen a thickness and they are elevating it. So with the tissue holding forceps, they are elevating the palatal area and they are placing it in the recipient side. I will tell you step by step management. Step by step, I will just let you know. Okay, this is the first step. First step, what they are doing, they are preparing the recipient side. So how they are preparing? They are using 15 blades. So 15 blades and they are existing at the mucogingival junction. So they are incising the mucogingival junction. So and then here the periosteum is intact, covering the bone. Okay, this is the first step. They will prepare the recipient side, leaving the periosteum intact. And then step 2, what? So they will obtain graft on the donor side. How they will obtain? They will use the sterile foil and they will see the measurement and they will keep it in the donor side and they will take exactly that measurement and they will bring it to recipient side. Okay? So when they are taking a graft, so this is one of the important things which you have to write it in the paper. Thickness. The thickness of the graft is very important. So you will have to take an intermediate thickness. So what is the intermediate thickness? 1 to 1.5. What happens if you take very thin graft? Necrosis will happen. Okay? You will not get a proper blood supply and all that. Necrosis will happen. What happens if you take a very thick graft? It will cause a very deeper wound in the donor area as well as the fluid accumulation. It will not be properly. Okay? So if you are harvesting a graft from the donor area, that is from the palate, from where to where you have to harvest, which is the safest distance. Okay, where you will start. Canine to second femora. We'll do it. Okay. So it is 7 to 13 mm of length you can harvest it. So finally you will transfer the graft and immobilize it. So when you are going to immobilize it, how do you immobilize it? First, you will suture the lateral borders. Okay, you will suture the lateral borders and then you will have to suture the periodarshan. There are two types of suture. This name you will have to mention in the paper, okay, in the exam paper. There are two types of suturing techniques. One is overbreak and then washer weight. So we have these two types of suture which you will have to mention in the paper. So and then finally you will have to protect the donor site. Okay, so to protect the donor site we have certain hemostatic agent. So the commonly used hemostatic agent are gel foam. We use the gel foam and we use oxygel. Oxygel is nothing but it is an oxidized cellulose. So we'll keep that and then we'll have something called as modified Hollis. So Hollis using Hollis appliance review. So we'll keep that for a retention purpose and all that. Okay. Okay, and then after FGG, we take the graft without involving what? Papilla. We don't involve the papilla, interdental papilla. Whereas gingival unit transfer, you transfer completely along with the marginal and the interdental tissues. Okay, you involve the marginal and the interdental tissues as well. So who introduced it? Allen and Cohen. So you have to know these names. Okay. So this is one of my case where they have taken an harvested a gingival graft. They have included the what? They have taken the interdental area also. They have included it. And finally, this was the result. So at the baseline, you can see the baseline width is 1 to 2 mm and the vestibular width is 12 to 13 mm. And after the treatment, how it is? So it has been improved to 3 to 4 mm and the vestibular width also has been improved to considerable amount. So if you have taken the graph, you will have to know about the healing phases. Okay, there are 3 different healing phases. What are they? Yes. Initial phase, revascularization phase, and tissue maturation phase. Initial phase, between what days the initial phase happens? 0 to 3 days. See, these are very simple contents which you can remember. When you go to surgical point of view, these are the simple points which you can remember and you can elaborate from them. So initial phase is between 0 to 3 days. Revascularization 2 to 11 days. It is between 2 weeks you will get a revascularization and finally tissue maturation happens 11 to 42 days. So at every phase you will have to remember at least minimum 2 points. So this is one of the important points. So initial phase 0 to 3 days, what happens? So how does the graft survive? So you will not get a blood supply. 0 to 3 days you will not get a proper blood supply also. But how does the graft survive? Every survive. Necrosis but how does the graft actually survive? Yes, plasmatic circulation. So what is plasmatic circulation? There will be a thin exudate between what? Graft and the recipient plate. So that is how it survives. And if there is a thick layer of exudate, what happened? There will be a resection in graft. So later what happens? The epithelium of this graft degenerates early. So it has to degenerate early in the initial healing phase and revascularization phase. Revascularization you have to get the blood supply back, you have to get the blood capillaries back and everything. Okay, that is called as revascularization phase. So what happens here? So there will be a capillaries. So when you get a blood capillaries, you will get a good blood supply. When you get a good blood supply, revascularization will be faster. And then finally you have tissue maturation. So tissue maturation, so it takes approximately 14 days here. In the tissue maturation, the way of finding the epithelium is there. No? Epithelium, it will gradually matures and forms a keratin layer. Tissue maturation, what should happen? Epithelium should mature and form what? Keratin layers. Okay? That is it. Simple. When you have seen a FGG, CTG is very, very simple. So why CTG is we call it as gold standard? because it has got dual blood supply. Whereas in FGG you have epithelium in one part and you don't have the other part. When you have an epithelium, you cannot get a blood supply there. So this is FGG. So other thing is they say it carries a genetic message. Okay, that is why it is very important. And reasons for the failure, like I said, if the graft is too thick, if you do a perforation, then you will have a failure of the graft. And if the recipient grade, preparation of recipient grade is too small, you will not get a proper blood supply. That is why you get a failure. And then we have apically deep position flap. Apically deep position flap is nothing, very simple. Here, can you see in the second picture that they give an horizontal incision and they apically deep position flap. They will bring down the flap and they will keep there and they will suture. Why they do that? Why they do this? To increase the keratinized tissue. Exactly. That is it. Very simple. So we have seen apical to recession, enala patha apical. So coronal to recession, we have coronally advanced flap and we have pedicle flap and we have pouch and tunnel and everything. Okay. So this is laterally displaced flap. So laterally displaced flap, in the first picture you can appreciate they have given both internal and as well as external incision. So and then they have given intracircular incision also. They have de-epithelialized this. Why do they de-epithelialize that site? To get blood supply. Like I said, no, if you have epithelium there, you will not get blood supply. So finally, they are moving the tissue which is adjacent to that area and they are placing to the recipient side, and between the graft and the flap, what they are placing? They are placing a CTG there. So you have seen a pedicle graft. Now we have to see coronally advanced flap. So in coronally advanced flap, you have different modification. So the one thing which you have to know is the classical technique which is done by Bernie Molan. So the second line is there now, 1975. Bernie Molan, you have to know that. So this is the step-by-step procedure of coronally advanced flap. Okay. So first you have to give a full thickness flap. In the first picture, can you appreciate the full thickness flap is raised? So it is between full thickness flap is raised. How? They have given two vertical incisions. Can you see there? Two vertical incisions are given and they have raised a full thickness flap. So and then inverse bevel. In the gingival margin area, can you see the red line above the gingival margin? So the inverse bevel line is given. So and then they have raised the flap completely. So and then they have advanced it. Can you see it is coronally 1 mm, it is coronally advanced and if they have placed it. I will show you the clinical pictures. So this is the clinical picture, okay? So they have given two vertical incision and the interdental area, so they did not involve the interdental area, just the beveling incision was given and then they have placed some CTG or something, they have coronally advanced it and they have placed it. Okay, so the modification of coronally advanced flap is something called like semilunar flap. Okay, in the semilunar flap, usually they have done it in the canine area. They just give only the semilunar incision and they will pull down the flap. Finally, we have recently done something called a Zubri's modification. So in this modification, if you have multiple tooth recession, what the author says is Zubri, what he says is you don't have to put any releasing incision. So in the vertical incision or releasing incision or you can give only the oblique incision and put the flap down. And if you have an isolated incision, then you can go for a releasing incision. That can be a trapezoidal form. Okay. Finally, the CTG. So you have to know at least the name of the harvesting technique. You are harvesting from the donor side, no? Donor side is the graft area. So other techniques what is the most common technique you know? Trap door. Trap door is redoor technique. So yeah, that is the most common technique. Here, trap door technique we give two vertical incision. Two vertical incision, one horizontal incision, and then we harvest only the connective tissue part. Epithelium will not involve the epithelium. Only in FGG we will involve the epithelium. Okay. And another one technique is Langer and Langer. So in the Langer and Langer, what he used is you use double blade. So can you see this double blade? So you can just give a small horizontal incision. You can insert this double blade, and with the desired thickness, what the thickness you want, you can just slit off that and you can take that. Okay. And then Liu and Weisgold classification. So he classified this harvesting technique based on the incision line. If you are going to give a 1 line or 2 line or U shape, L shape, so it is that way. Okay. And then finally you have double papilla flap. So one of the indication is when you have an interproximal papilla adjacent to the mucogingival thing. So if it's not suffice, then you can use it. So oblique rotational flap, this flap, so we are not using it much now. So at least know there is this one flap that existed and it was introduced by Pennell in 1965. The other techniques, so we have done with the two types of technique. Apicala enna pannuvom, coronala enna pannuvom. So we have done two types of technique. Idhiliye vandu there are few conservative techniques like pouch and tunnel technique, pinhole technique, vista technique. So vista technique na enna? So in the vestibule we will give an incision. Vestibular incision, subperiosteal tunnel. So we will create a tunnel and with that axis we will do this thing. Okay, so like I said, you have pouch and tunnel technique. Usually we do it in the anterior region, in the area where there is an aesthetic concern. So in that region we do, and then like I said, no vista. So give incision in the where vestibule and use biological membrane. Do you know? Have you heard about PRF, APRF, advanced platelet-rich fibrin, platelet-rich fibrin, and all that? There are such type of biological membrane, and another commercially available biological membranes are there that you can insert it. So finally, we have microsurgeries. So microsurgeries na enna? So you will use microscopes, loops for a better vision, and you will do a very conservative management of the gingival recession, and then you will do it. So we conclude by saying the gingival recession is one of the most aesthetic complaint that we often get it. Okay. Apart from aesthetic complaint, there is sensitivity and root caries. So these are the two things. So this also, these points also should be there in your paper. Okay. When you are ending it, so then only it will look good. Okay. So finally, we have different procedures. There are various procedures for what? Root coverage. So recession, for the various procedures for recession. But you will have to know for what type of recession, what technique it will suit. That is why we have read what classification. That is there. And though choosing the proper appropriate treatment and surgical technique will recommend a good predictable outcome. Okay. Thank you. So I am sharing this PPT. Okay. So you can get from your teachers. So you can read it. So this is exactly put in the point wise. You can use the same for your exam purpose also. Okay. Thank you.
Thank you so much, sir. It was very detailed one. Any doubts from the audience? It's a very clinical topic actually, more clinical than whatever seen from yesterday. Any doubts?
Or amazing.
Okay, students, please do not leave for lunch. There's a small change in the plans. Since it's raining and all of you want to leave early, we are going to complete the quiz right now. Okay? So it will take only 20 to 25 minutes, after which you can take your lunches and then you can proceed for your homes. Yes? So just wait for 5 or 10 minutes, we complete the quiz now. Asikila?
ஸ்டூடெண்ட்ஸ் கீழே தான் இருப்பாங்க. என்ன ஒரு செமினார் உட்காரட்டும், அரேஞ்ச் ஆகட்டும், எப்படி கவர் ஆகும்.
Students, I request you all to please settle down. I now request Dr. Ashokan sir, Professor in Head Department of Oral Medicine, to felicitate the guest speaker, Dr. Shankar Prasad sir. I request the quiz teams to come forward and take their seats. Two teams from Tagur. Please take your seats. Two teams from Periodarshan. Please step forward and take your seats. Two teams from Balaji. Any representative from Balaji?
Who's the chemistry? First round will be a simple question and answer round. Okay? One team will be eliminated after round 1. Okay, it's a simple question and answer round. We give 30 seconds to answer. Okay, whatever answer you're telling first will be considered. Okay, so this will be team A, team B, team C, team D, team A, B, C, D, E, and F. A, B, C, D, E, and F. Okay? So, first question for team A. What is enamel? It's wrong. Anyone else? See that there's no passover. It's existential new attachment procedure. Team B. It's a system. Time out. Anyone? EDA system, enhanced visual assessment system for correcting subjective restorations. Next question for team C.
ஒரு வியூ இந்த ஒரு
Anyone? Store like receptors. Store like receptors. Okay, team D. I said this one. No? Time out. Low level laser therapy. For team E. Yes? Can you stand? Polymorph from nuclei? Yes. Team F. That's the wrong answer. Again, second set of questions will start. So, Team A. Next question to Team B. Eight seconds more. Tell something. It's a wrong answer. More than 9 seconds. Team C. Very simple. Correct answer. Team B. Again, a very important point. Very important. It's a wrong answer. So Team B. It's actually simple if you could notice clearly. WAG is width of attached gingiva, WKG is width of keratosis gingiva, and I think you know the rest. Timer. And that's why you should at least try. Sometimes you might get this. அது ஆப்ஷனே இல்லை ஒரே கேஸோட இது I'm sorry. Team F. Horizontal component. We are over again to Team A. Yes? Concentration. Doxycycline is way too easy, it's there in the answer. Concentration. Yes.
It's a wrong answer. Next, team B. It's a wrong answer. C.
You still have 10 seconds. Yeah, correct answer. So this is for team E. Audience, please maintain silence. Sura pocket. Yeah, correct answer. The question is not for team F. Must be yes, but already you told the first answer will be counted, okay? So moving on to team A again. So you still have 15 seconds. Yeah, correct answer. Moving on to team B. Next question is for team C.